Welcome back to Ellie Scrubs In. Today we're doing something different. A rapid tour through a cross-specialty set of instruments you may not have seen together. Orthopedic, thoracic, ophthalmic, general, and neurosurgical tools that show up in diverse operating rooms. By the end, you'll know what they look like, how they're used, and what to watch out for when you scrub in. Let's scrub up and dive in. Hohmann Retractor. The Hohmann Retractor is an orthopedic staple for exposing bone. Picture a single, flat blade with a narrow neck and a broad handle. At the end of the blade is a small lip or beak that catches on the cortex. In practice, the surgeon slides the blade along the periosteum and levers soft tissue away to reveal the bony surface for plating, reaming, or joint work. You'll see Hohmanns in fracture fixation around the femur, tibia, radius, and ulna, and in joint exposure for total hips or knees. Sizes vary, short, medium, long, and some have a small spike near the tip for purchase in dense fascia. Placement is everything. The assistant seats the beak on bone, not in muscle, then applies steady counter traction with the handle oriented so it won't drift into the field. The instrument works like a pry bar. Small movement near the tip yields powerful tissue displacement. Because it's thin, it fits where bulkier retractors don't, between muscle bellies, under tendinous planes, around the metaphysis. When used near neurovascular bundles, think femoral triangle or popliteal fossa, mind the angle so pressure doesn't transfer to vessels or nerves. For knees, the Hohmann helps subluxate the patella or protect the collateral ligaments while saw cuts are made. For hips, it helps elevate the abductors and capsule during anterolateral or direct anterior approaches. In distal radius, a tiny Hohmann exposes the volar rim while protecting flexors and median nerve. If bone wax is being applied or a plate is being positioned, the Hohmann holds tissue out of the way without the bulk of a self-retainer. Seat the beak on bone and keep continuous, quiet tension. If soft tissue blanches or the retractor walks, you're not on cortex. Reset before proceeding. Pitfall. Levering against neurovascular corridors or the periosteum too aggressively can cause neuropraxia or cortical gouging. Recheck position after each power tool step. Mikulicz Peritoneal Forceps. The Mikulicz Peritoneal Forceps are ring-handled clamps designed to grasp and elevate peritoneum and thin, soft tissue flaps during abdominal and pelvic surgery. They typically have curved jaws, a ratcheted lock, and may feature 1 by 2 teeth or fine serrations to secure a delicate peritoneal edge without slipping. Common lengths are about 18.5 to 20.5 centimeters, with light and heavy patterns and angled variants for deep or narrow fields. In the OR, you'll see them used when the surgeon wants a controlled lift on a thin, mobile layer, tenting the peritoneum for safe entry, holding a peritoneal flap during pelvic dissection, or stabilizing an edge while scissors create or extend a window. Because the jaws are shaped for purchase rather than crushing, they're ideal when you need traction on a slippery sheet of peritoneum without tearing it. Think of them as your go-to for precise, atraumatic control of peritoneal tissue. Pearl. If your forceps have 1 by 2 teeth, let the tooth engage the tough edge of peritoneum or fascia, not the thin, unsupported sheet. That tiny bite gives you anti-slip security with minimal pressure. For deeper angles, like a narrow pelvis, consider the angled or heavy pattern for better reach and stability. Pitfall. Don't treat Mikulicz peritoneal forceps like crushing clamps. Over-squeezing a thin peritoneal veil will tear it, and aggressive traction can propagate a rent into mesentery. If you find yourself pulling hard, switch strategy. Shorten your bite to the reinforced edge, or use a different instrument meant for heavier traction. Argon beam coagulator. The Argon beam coagulator is a monopolar energy modality that uses a jet of argon gas to carry radiofrequency current across a short, visible plasma arc. The result is broad, superficial coagulation that's perfect for raw, oozing surfaces. Think liver bed after cholecystectomy, splenic capsular tears, and tumor debulking fields. Instead of touching tissue with a tip, you paint hemostasis from a small distance, creating a uniform eschar with relatively shallow depth of penetration. The handpiece emits argon gas, which ionizes and directs current to the nearest conductive tissue. Because the effect is mostly superficial, you control ooze without over-penetration. It's superb for wide fields where pinpoint cautery would be slow and where tissue contact could tear friable surfaces. Technique looks like airbrushing. Keep the tip moving, use low to moderate power, and maintain a consistent standoff distance. In laparoscopy, mind the pneumoperitoneum and ensure adequate venting. Gas stacking can impair visualization. Think, paint, and move. Short, sweeping passes prevent charring and create an even coagulum that's easy to reassess. Pitfall. Rare but serious. Gas embolism is possible if you fire directly into open vessels or deep cavities without venting. Avoid prolonged activation in one spot. Never drill into tissue. Castroviejo needle holder. The Castroviejo is the microsurgeon's needle holder. Spring-handled, light, exquisitely precise. You'll see it in ophthalmology, plastics, neurosurgery, ENT, and microvascular work. It's designed for very fine needles and sutures. 7/0 to 10/0 are common, where even slight hand tremor matters. The handles open and close with gentle finger pressure. Some models have a side lock, others are no lock for rapid fluid work. Using it feels different from a standard Mayo Hagar. The grip is pencil-like. Motion comes from small finger movements, rather than wrist torque. The jaws, often with diamond dust or micro cross-hatching, grip fine needles without marring. Load the needle about 2/3 from the tip, perpendicular to the holder, and drive arcs that mirror the needle's curvature. In vascular anastomosis, you'll pass bites 1 to 2 millimeters from the edge, averting the intima while avoiding back walling. In eyelid or facial closures, you'll place precise, shallow bites that respect skin tension lines. Assist instruments matter. Pair the Castroviejo with fine forceps, like Adson's with fine teeth or Bishop-Harmon Forceps, to present tissue and follow the needle tip. Keep the field dry. A single droplet magnified through loops can obscure the target. When tying, keep suture tension smooth. Abrupt pulls can snap 9/0 or 10/0 like hair. Pearl. Rest your forearms, anchor your ulnar border, and use the table for stability. Mechanical quieting improves accuracy more than any grip trick. Pitfall. Overlocking or crushing microneedles dulls them instantly. If the bite feels crunchy, swap the needle rather than force it and tear tissue. Bishop-Harmon Forceps. Bishop-Harmon Forceps are delicate ophthalmic forceps used to handle fine tissue with control and minimal trauma. They come in smooth and toothed variants, with a small platform near the tip that's perfect for tying microsutures. In eye cases, they position the conjunctival edge. In plastics, they lift thin dermal flaps. In microvascular setups, they help present vessel edges for precise bites. Because the tip is so fine, you handle tissue more by support than by pinch. Imagine floating the tissue onto the platform, rather than squeezing it between teeth. When assisting a Castroviejo, you track the needle tip, gently chase the curve through, then release just as the needle exits, like passing a baton. In eyelid repairs, they let you pick up the gray line without crushing it. In cartilage work, they present a perichondrial edge cleanly for closure. Pearl. Use the tying platform, rest the suture across it, and rotate your wrist to guide square, low-profile knots without sawing the tissue edge. Pitfall. Treat them like Adsons, and you're likely to bruise or tear delicate layers. If you need traction, switch to an instrument designed for it. Finochietto Rib Spreader. The Finochietto is the iconic thoracic retractor for open thoracotomy. Two broad, curved blades slide apart on a ratcheted rack. A hand crank opens the chest wall by spreading adjacent ribs. When you need access to the pleural cavity for lobectomy, decortication, esophageal surgery, or trauma control, this is the workhorse. Positioning starts with identifying the intended interspace and protecting the intercostal neurovascular bundle that runs along the inferior rib margin. Blades go just inside the ribs, often with a moist pad between blade and periosteum to reduce crush. The rack sits outside, parallel to the ribs. Opening is slow, incremental. 1 or 2 clicks, pause, let tissues accommodate, then another click. Overzealous cranking risks rib fracture, intercostal nerve injury, and postoperative pain. Once open, the spreader becomes a biomechanical doorstop, stable but not set and forget. Reassess pads, check lung edges, confirm the pericardium or diaphragm isn't snagged. For long cases, tiny adjustments reduce pressure injury. At closure, de-ratchet gradually to avoid abrupt chest wall snapback, evacuate residual air, and ensure the lung is fully expanded before the final stitch. Pad the blades and respect the inferior rib margin. Most nerve injuries come from compressing the neurovascular bundle against bone. Opening too fast or too wide creates fractures you don't discover until postoperative imaging, or bleeding you discover right away. Kerrison Rongeur. The Kerrison Rongeur is the precision bone punch used in spine and skull base work to remove thin bones safely. It has a slender footplate that slides under the lamina, or bone edge, and an up-biting or down-biting jaw that takes measured bites of bone, commonly 1 to 5 millimeters. In laminectomies, it thins and removes lamina. In foraminotomies, it frees nerve roots. In ENT or neurosurgery, it shapes the bony canal with exquisite control. The rule of Kerrison's: see the footplate. If you can't visualize the tip under bone, you don't bite. The assistant keeps suction and light on the working edge, while the surgeon advances the footplate, feels the undersurface, and closes the handle to remove a wafer of bone. Progress is incremental, small, controlled bites that preserve landmarks. Up-biting versions work when you're under a ledge. Down-biting versions help when the angle is reversed. Size selection matches the anatomy. Too big and you'll chatter or lever. Too small and you'll be inefficient. Pearl. Thin with a burr, finish with a Kerrison. Pre-thinning bone reduces force needed and gives cleaner, safer bites near dura and nerve roots. Hidden dura is the enemy. If the footplate isn't fully under bone, or you're biting where ligamentum flavum is tented, you risk dural tears and postoperative CSF leaks. That's our special cross-specialty instrument tour. 7 tools from bone to brain to chest and micro. If this helped connect some dots across services, hit subscribe, turn on notifications, and share it with your classmates or co-residents. Drop a comment with the next instrument you want covered. Vascular clamps, ENT micro tools, or spine trays, and we'll add it to the lineup. This is Ellie Scrubs In. See you in the next case.